Thank you.
Gostaria agora de convidar Dr. Cláudio Maierovich.
I would like to invite Dr. Cláudio Maierovich, that he's going to be the moderator for the next test session, self-test as a public health tool. He's a sanitation doctor. He's working FioCruz, but he was the director, he's a president, and he worked in the Ministry of Health in one of the boards, if I'm not mistaken, SVS. So Cláudio, please welcome. The floor is yours. Thank you very much. Good afternoon. Thank you for the kind presentation, Carlos. At first, I would like to congratulate the audience, congratulate Carlos on his effort of more than decades that he's successfully bringing the diagnosis area to the core of discussions, and he was able to bring to another level in the scientific discussion, the technological discussion, and also the access of healthcare in Brazil. I will congratulate Laeticia also in being successful in implementing Alavive. I would like to mention Aladiv partner, CBDL, Professor Rosana, present in the event. It's a satisfaction to participate in this first table. It was quite stimulating. So I will allow myself to make some brief comments around our topic. That's the self-tests as a tool for public health. COVID, that we lived as a tragedy in the entire world, particularly in Brazil, is the biggest humanitarian tragedy recognized in our history, without considering other tragedies that we had before the past. But we live COVID as a crisis that started and came upon us when some changes we had we changed some paradigms, not only in Brazil. This was happening. It was happening in a lot of places, especially in nations with high income, but some that we had as possible revolutions in the health area. I will mention here the incorporation of tools that embed artificial intelligence in diagnosis area, in treatment area, epidemiology, also telemedicine, that in our country was seen in a careful way with a lot of taboos involved, because between the pillars of our medical organization, the traditional one, it was always the direct contact between physician and patient and the professional health service. It changed completely during the pandemic. I think that we are learning a lot with that. And in the diagnosis area, the fast tests, point of care that we call, it were being used as technologies in our health system in a lower speed than the innovation capacity that they represented. Once that talking about fast tests that's done, the point of care tests, it's a reorganization of the diagnosis area that's not related to not only to the kits, to the materials used for the tests themselves, but a reorganization of the services, of the flow of people, users, professionals, and also the information flow in the system. Also, in the diagnosis area, in the Brazilian case, an action that maybe wouldn't be enough compared to the auto tests that we had from Brazil. It was the self-tests for pregnancy only. The other tests to measure glycosis with stripes and devices that people keep at home. And we were following the recent embed the recent use. I think that we're going to have a discussion about this, about the self-test for HIV in Brazil. And with that, we had technological modifications with high potential as the multiplex tests, the same test being able to diagnose, to have the diagnosis of different diseases using PCR technique or point of care. So these things are the background of what we live nowadays as an innovation potential. We went to the self-test discussion of COVID in Brazil in the end of last year. So we had a lot of discussions about that, but we should remember that some of the attributes of this as an advantage for these self-tests that we had in the discussions. Attributes as being ease, faster, the privacy, the possibility of reducing the cost of the system, biosafety, as the person doesn't need to go to a place to do the test. It was mentioned before by Hosanna. And the autonomy and the possibility that people can have on their reach a device that allow them to have the diagnosis and doesn't depend on third parties. These are innovative things.
And now we see that there are many possibilities for future perspectives. And we should always remember that in our point of view, and this is the topic of this discussion, it's not only looking at technologies, but also how appropriate and how much it's possible to have new technologies as public policies. And for that, we have a lot of different paths related to the technological matter itself. We have aspects that are not only regulatory, but they are aspects related to quality and trust from professionals and test users that may demand some type of process that today is not enough on the controls that are done for the registration. So it's a moment to consider possibilities and certifications, or as auto tests are assisted technologies, the self-tests are based on technologies and what we can achieve through accreditation as well. Just to remind you, we will have many tasks for different factors. We have what we already mentioned in terms of the costs, like we talked about before. It was very frustrating for professionals that need to defend COVID self-test to see that the self-tests came to Brazilian retail with prices very similar to the tests that were done in the pharmacy, the antigen rapid tests. So this means there's a big variety of topics that need to be approached, that need to be handled so we can evolve. So now I'm going to use the terminology that Carlos Morello used, ex-president of FioCruz, when we see that we already have enough knowledge for this. So it's not a science failure, but there are market failures to see that these products have high prices, low competitiveness, and maybe not and it still exists in the service market, and there isn't a public policy for the offer of the tests. So these are topics for us to approach through this time. And for that, other than topics that are considered related to the interest of anyone who wants to present, I'm going to ask Mariana Vilares to come forth. She's a master's in engineering for innovation, and she leads the team responsible for in vitro diagnosis on the, I always confuse this, chronic infection conditions for the Ministry of Health. So she's responsible for in vitro diagnosis, and she has been working with important innovations, among those, the one I mentioned. And now um, I invite her to tell us about the experience with Brazilian self-test. Hello, everyone. My name is Mariana. Thank you for your presentation. It's very nice to be here. I'm very grateful to be here to tell you a little bit and show the experience we've had in Brazil with the HIV self-test for our public health system, how we implemented this with public policies in Brazil. To give you some context, I don't know if everyone who's on this event understands a lot about HIV, but just to give you context, we have the 3 cascade bars for HIV in Brazil. And the first bar, which is the diagnosed bar on the left-hand side, we can see that in 2012, we had 69% of people living with diagnosed HIV in Brazil. And in 2020, we had 88% of people with HIV diagnosed. This is completely related to the rapid test implementation of HIV on the primary care facilities. We talked about this in 2012 and we expanded a lot. And we take the test up to the user from 2012 to 2020. That was a main difference. Anyway, the closer we are to 100%, the closer for us to reach our goal, the harder it is for us to be able to increase the percentage. So it's a huge challenge. How can we increase diagnosis? Because we reached 88% of diagnosed people. How do we reach 100%? How do we find these people? And knowing that in Brazil, we have a concentrated epidemic, the prevalence of the general population is 0.4%. And in other populations, for example, gays and other, we have 18.4%. Sex workers, women who are sex workers, 5.3%, and trans women, 17% pretty much. We have a concentrated epidemic, and to be able to get out from 88% and get to 99, 100%, we need to focus on this population. And at the same time that this population is the population that is not being reached, that is the most vulnerable population that have a hard time accessing primary care. So for that, we need a strategy that has focus and accessibility to make sure every population has diagnosis. With that, since 2018, Brazil implemented the HIV self-test with another strategy to implement this diagnosis in the Brazilian public health system. How does the distribution of self-tests work for HIV in Brazil? We have a goal of reaching people who are not diagnosed, which are the ones that are facing some challenges. So the focus is keep and prioritize population that are not reached by our regular public health system. And what are the main strategies that we use to reach this population? The distribution of self-test outside health services, and also the secondary distribution, which is between pairs and partnerships to make the test reach the population that it currently doesn't. So we have 3 main strategies for distribution of self-tests for HIV in Brazil. The first one is for PrEP users, for them to deliver this to pairs and sexual partners. We know that PrEP users are people who are vulnerable, that probably are among others who they know who are still in the same situation. So it's a great strategy to make the PrEP people help us reach other people who need to be tested, but they don't use these health services. Another strategy that we have is distribution in social location for key population and priority populations that can be done by health professionals or civil society organizations. So these are distributions outside the health services where the populations are. So parties, bars, social places, to be able to reach this population. Lastly, people who go to health services so that they can deliver them to friends and sexual partners. The auto test, the self test is not going to substitute the technology, the professional technology, like we said for COVID, but it's another tool to be able to broaden the possibility. So for health services, they're going to have the test on the health location or the primary care unit, but they can take the self-test to friends and sexual partners. And the Brazilian strategy contemplates that each of these people can take one self-test for themselves and up to 5 self-tests for other people. These guidance are inside this document that is on the right-hand side of the slide, which is on our website as well. So all of those strategies that we use in the Brazilian public health system are in this document. I'm creating a parallel with what was mentioned before as well about information and communication. So when we're talking about self-test, which is a tool that the user is not a health professional and they're going to do this at home or somewhere else, it's important that they have full information and clear information. So when should they take the test? Where can they take the test? And depending on the result of the test, what are they going to do? What are the next steps? And it's also very important to have support if it's over the phone or other channels so that the user can ask any questions if it's necessary. So we have a specific website about the HIV self-test. And inside this website, there's a lot of sessions, different sections with information so that the users have all the necessary information for the test. So we have pamphlets to be delivered with the test, posters that can be pasted where they offer self-tests. We have videos showing how to perform the self-test. We also have a video saying what the self-test is. We have a man and a woman, and they have the characteristics of the general population and the key population as well. The characters in the video, they talk a little bit about health. So it's like 1 minute video. We also have an interactive panel as part of this strategy in Brazil. And we also have a FAQ section so that the user can go in there and see questions that are commonly asked. About monitoring. Monitoring is going to help us make decisions to adjust the strategy and also update public policies whenever we think is necessary. This has been very important throughout our process ever since 2018. Everything that we find in our strategies, we are able to adjust to make that strategy better. So for monitoring, we have the 2 main tools: filling out an anonymous form with information about sexuality and location. It's a very short form. I think it's 6 or 7 questions. There are multiple choice. And the most important thing is that it's anonymous, because this cannot be an imperative for the person to grab a self-test. It has to be simple and quick. And we also have another way of recording this information, which is for people who are already patients in public health system, or people who live with HIV or in PrEP, who can bring these to partners, the consultation applications that we have. And I brought some result data from this policy to show how important this is for us. We started in December 2018 with a pilot in 14 municipalities. And in January of 2020, we were able to open it to Brazil as a whole. With the success that we had and with the population that we reached, which was the goal population, we were able to open it to Brazil as a whole in 2020. Then we had the pandemic. In April 2020, we have the recommendation about social distancing. So we saw a little bit of a break in the distribution, but we had a few webinars and we had a lot of incentive towards using self-tests because of the recommendation of social distancing. So this was a way of maintaining the testing offer for the test population and for priority population during this recommendation of social distancing. and a lot of people were afraid of the health system, so we stressed this, and it brought a great growth until September to October, November. We had high levels of distribution of the self-test in Brazil, and this growth ended the stock for our self-tests. We purchased again in April 2021. We had the new purchase, we received the new test, and we can say that it went up drastically as well. So far, we have the distribution of 419,795 self-tests on the different strategies that we have in Brazil. Here, I'm showing the amount of municipalities that are a part of the strategy. So there's also a growth and reduction, then growth again. So in November, 124 municipalities distributed it in Brazil, and accumulated the municipalities who have distributed at least one, so it's 256, and we want to keep increasing that over the next couple of months. And here I have some distribution data, some results from our distribution. So in average, we have 3 self-tests registered per person. Like I said, each person could grab 1 self-test for themselves and up to 5 for friends and partners. So we have an average of 3 self-tests that were gotten from people who have HIV and want to bring this to partners, and people who are in PrEP and want to bring it to partners as well. And for the distribution outside these services, the average is a little bit smaller. It's 3.2. So people who are approached in the street or the sociability actions, we have a smaller average. Maybe because these people are very used to having self-tests, maybe they aren't as shy as to getting the self-test.
About the age of people that receive the self-test, it's an important information. 20% of the people that receive the self-test, that not necessarily these people took the self-test. We're talking about the distribution. 20% of them was between 18 and 24 years old. That's a young population, and that we know the young population, especially in Brazil, they are suffering a lot with new diagnoses. And 22% of the population that received the self-test was 25, 29 years old. So 42% of the self-test was distributed for people in between 18 and 29 years old. On the right side, we have a chart that's quite important. That's a data from the form. That's when was the last test for HIV that the person did. And 20% that got the self-test never have done this before. It was the first time that they did this, what shows that we have a strategy focused on getting into this population. We have 13% of people that tested more than 2 years, that we know that the population needs to be tested with a higher frequency. And an important data, as I'm talking about young people, that people that have never done the test, when we go to the people between 18 and 24, 20% have never tested before for HIV. So we believe that this distribution of the test is being able to reach these young people. About the gender identity, the majority of them, if I'm not mistaken, 52% of the population are gay people. And I get your attention to the trans population. We have only 5% of this distributed to the trans population. We're trying to have an effort to reach this population. That's a population that needs this technology. People that have some issues about going to the health system. So it is a little bit higher, but we'd like to increase even more this percentage. About race and color, we are divided. 50% said that they were white or yellow, 49% black people, and 1,000 indigenous people. And this is just a slide to show that this data that I showed, they are the interactive panel. We have the address here, where I'm going to share this presentation. If you want, you can filter this by state. for each type of strategy, in each unit, in each state, everything is available in our website if you want to check the strategy in Brazil. And this other one, and bringing something new that I didn't present the other times, we are applying a questionnaire after the test. These are distribution data. The people that received the test not necessarily were the people that took the test. So since the beginning of the strategy, we had a post-test questionnaire. So for those who took the test, you go there, it's anonymous, and the person could answer some questions to us so we know how people are accepting this test. How is the population that's using the test? This in our website too. And if you pay attention to it, in the label of the self-test distributed, in the end of that, there's a QR code that goes to this questionnaire, so it's easier to the user after doing the test to report to us this information. And also in a brochure that we delivers with the self-test, there is the QR code so people can go there and answer this. But it is a voluntary answer and is not something mandatory, so we don't receive so many answers from the distributed tests. But we have interesting data of this post-test questionnaire. If it's from January 2021, we had 813 answers. I think that we have 1,300 right now. 45% of them that answered this were gay men. 50% was between 18 and 29 years old. 45% reported having anal sex without protection in the last 6 months. 32% were taking the self-test for the first time, and 32% have never done this test. If we go to that range of 18 to 24, so they have never done a test like this before. About accepting this, 91% of people thought that it was easy, 98% said that would take the test again, and 99% would recommend the test to a friend. These two charts are interesting. It shows to whom the person took the test, how they were able to get the test. So to summarize, the persons who took the test, 80% of the people, even though there's the possibility to have support from a health professional, 80% of the people didn't use the support. A lot of people, it got our attention. A third of them have done with a friend, a partner, or someone from the family. So in Brazil, they are taking the test with other people. And how they got the test, they can buy this in the drugstore. It was available. They can get the health service, can receive from an NGO, or get from a friend. It shows that if 53% of the people that answered this questionnaire got the self-test outside the health service. So it shows that we're able to reach people that not necessarily are going there to these services. The last one, two important results from the people that answered. We have 34% of people said that they had a radiant result. In Brazil, 0.4%. This is wrong, this data. And from these people, 79%, they already tried a health service to have complementary tests that sometimes are afraid when they do the self-test, they don't go to the service. So they answer to the questionnaire. 79% have gone to a health sector to get this to get health help. So they had the questionnaire as the main advantages of the self-test. First, the privacy. 72% said that this was an advantage. And personal empowerment. 51% said this is also an advantage. I think that was what I wanted to present. I think I'm over the time. So thank you for the opportunity to present this strategy to you. And I'm available to answer questions. Thank you very much, Mariana. Quite interesting, your presentation. I think that, again, it shows how important is this public health. Since we started this AIDS program, that we have other things now, we have hepatitis, we have other diseases, and now working with tuberculosis and other disease. that helps to get new models with the public health area. So congratulations for your presentation. Now I will invite right now Dr. Patricia Garcia, that's a sanitation doctor, was the Minister of Health from Peru, and a researcher in that country too. So please, the floor is yours, Dr. Patricia.
Muchísimas gracias. Voy a compartir mi pantalla. A ver.
Thank you very much. I will share my screen.
¿Se puede ver?
Perfecto, listo.
Can you
Listo.
see my presentation?
Voy a comenzar agradeciendo a Carlos y a
I'll start
todo el equipo que ha
thanking
organizado
Carlos
toda esta presentación.
and everyone that organized
Quiero ver cómo
this
apago
activity.
el translation acá. ¿Cómo lo hago?
Now she's trying to turn off the translation for
Yeah.
her.
Interpretation off. Okay. Ahora sí. Muchísimas gracias
I was
por
able
la
to do
invitación.
it. So thank you very much for inviting me, and congratulations, Carlos, for your leadership in these topics that are related to diagnosis test. I will speak in Spanish because we are in talking to Latin America, and I know that a lot of people that speak Portuguese can understand Spanish, and we also have simultaneous translation. The topic today is self-test as a tool of public health in a globalized world. So let's start talking that of the point of view of the language. I mean using self-test. I know that in Portuguese you use the same, but we need to be sure that this is the right word to use. So I use this word in Spanish, but I think that we need to maybe to have a specific word in Spanish. I don't know how people would understand this. When I was talking about this in Spanish, is related to car. Are you testing a car? So this is something new. So we need to make sure that people understand well. And if people understand, they can know what's going on. So the health in this century is changing. So we have the demographic change, we have pandemics, we have climate change, humanitarian crisis, mental health problems that represent an increased load of diseases in the interconnected world, social pressure, and technological pressure. Things are changing in the world in this century and also for the health. As someone brilliant said, we cannot intend to do different things if we don't change what we do. And the challenge in this century is how to adapt the health system in public health to promote the prevention and to make sure that we have the access to health care so we have resilient service. With the health concept that we have for the community, and for that, we would need to have a technological development and innovation. And this innovation needs to be accessible and the right one for the different needs, the different means in reality. And that can be environmental friendly, that needs to be close to the community. And one of these concepts is a new concept because we need new things for this world that's changing so much. The concept of an intervention of self-care, that's also a translation that we have from English. So it's called self-care intervention in English. So the WHO has a guide for self-care. So these guidelines are about drugs, diagnosis, products, and technologies based in evidences that can be totally or partially separate from the health services that can be used without the support from a health worker. And on the right side, you can see in all these interventions of self-care, the self-testing is an important part of that, and the self-tests are the ones that can be diagnosis tests that allow to have your own screening, your self-diagnosis, or even the self-monitoring. So the WHO gave this guideline in this context that we need to empower people in a number of aspects, and one of this is related to self-testing. A Lancet Commission for Diagnosis and Testing, in the report published in October 2021 about how to transform the diagnosis tests, we had 7 key messages. The first one, almost 50% of the world population has low or no access to diagnosis tests. And this is related to the fact that is not financed because they are related to levels that people are not able to achieve. That's why I would like to go to the primary care because this is fundamental to improve equity, and also that innovation that are new can help us to transform this access and can be more democratized. An example of that, of the self-test, to work this transformation, we could avoid at least 1.1 million of deaths per year with a better access to diagnosed tests, thinking about only key diseases.
Each dollar goes to many dollars in benefits, and it's interesting to understand why it's important and why we're going to use it in an effort for public health. The innovations, recent innovation can make the process more democratic because the tests can somehow be digitalized in the attention point. And we already have examples of tests that are so simple, so stable, and maybe so easy that they can be used as self-test. The experience in Brazil with the HIV is very interesting. And in some of our countries, we tried this experience, but so far there is a series of barriers and this wasn't able to be implemented on a national level. But the innovation is out there. And I believe that in the context, it's important to talk about how we can convert these tests into tools for public health. Now, the citizens are interested in diagnostic tests and self-tests as well. We have studies in Peru for very long ago of using self-tests and shows that most people would like to use the self-test instead of regular tests. And they would just ask for us to have clear instructions and somehow a guidance of what do you do with the result, which means reference. We did these studies in general population in different places, and we were going specifically towards asking about tests related to pregnant women, sick children. However, it was too broad. The need that we found was too broad from the citizens to have access because they believe in the technology. What they told us is that they would prefer the type of sample as well. So, for example, saliva instead of blood. But however, when it was a prick in the finger, that was also acceptable to people. Other than that, women and men are willing to pay for self tests that are sold freely. And even though we have uh, health insurance in the country, which is or a public health system, what we understand is that the system many times don't have everything. Some things are lacking. So we say if it's not as expensive, we can pay for it ourselves. And the that can create inequality as well because the ones that can pay will and the ones that can't won't have the test. However, the citizens are interested in that. They are not afraid of it. And to see how self-tests can really approach critical challenges in public health, I wanted to bring an example, which is one that we are working with, which has to do with the cancer in the uterus cancer, and women die in Peru every 5 hours because of this uterus cancer. And this is because of this cervical cancer makes them afraid to go to have a pap smear. And most women are diagnosed only in very advanced stages, even though they did a lot of pap smear tests. Now we know that the HPV that causes this cervical cancer, we have a lot of things to capture HPV and to catch the problem before we reach cervical cancer. So we have molecular tests that are easy to do with accessible cost, and they can be done by women at home. Another way of self-test, which is the self-sample. So the woman will get her own sample. This is quick and easy and makes them more, they have more self-esteem, they save time, they have privacy and autonomy. And women in a capacitated community can talk to other women, and this can be very powerful to share this knowledge, self-test and self-care. This is what we have been working with. And we have been working with the HOPE model. And what we want to do is we want to create this model where people talk to other women. You get the self-test, you take it at home, and these samples can be deposited in collection places. The samples are gathered once a week in bikes. They are processed, and if they are possible, if they have a positive result, we would reduce the number of women who really needed to go to the healthcare center to have treatment corresponding to that, and then we would focus our attention on those women. Based on that, we have changed regulation, national regulation. However, there is still a little bit of resistance on the professional side, letting women take the test at home and getting the sample at home. In some places, as we said, they said, no, it's better if we monitor them. However, we already have in the country some models where this is being done and it's advancing, and women are empowered by that, and they are taking their own samples and their own tests. And this showed us that it increases our coverage. This is an example that we are still working on the implementation, and we went to implementation on a nationwide level. However, it hasn't been easy, as I've been telling you. However, the pandemic is giving us new opportunities. As Rosana said, all over the world, the tests were. However, the test centers and health centers are overloaded with people. And when we have these antigen tests that were available, they were quick for one, and two, they gave us the opportunity for self-test. But due to existing regulation in many countries, and one of these countries is my country, Peru, in many countries, we couldn't introduce this fact of having self-diagnosis or self-test, or being able to have the tests available for people so that they could do it themselves. However, and even though Peru started very early and they were using the rapid tests, it was always tests that were done by health professionals. So we suffered a lot with this overload in our health establishments and our test centers. But the concepts, and this is because we are in a globalized world, the self-test concept came to the country through social media and through a lot of factors. And people, the public, actually started to ask why in other countries they have self-test and it's not allowed here. And this created a demand. And our office, which is the regulator of medication and medical devices, including diagnostic testing in Peru, finally recently has approved the availability of self-tests for COVID in pharmacies. For that, we had to review and recreate some regulations, but they were only temporary and specific for the self-test. However, this increased autonomy, reduced risk, saved time because people could just go to the pharmacy. At the beginning, this also conditioned some issues because number one, the tests were really expensive and there was no control for prices. Whoever could pay for them did, and they had a lot of tests at home, and that was it. There was no control, quality control of the tests that were sold. And more than that, there was a parallel market of selling tests online, which were not very well managed. And a lot of us working in public health, working with written and television media, we started approaching the topic that the tests that were sold online didn't have any control, and we needed to pay attention to that. Another problem that came up was segment and result notification. But in the middle of the third wave that we had, being able to have tests or self-tests has allowed somehow to reduce the pressure that was there, the problems that we had because people were demanding to have tests, they needed to have tests, and no one, not the private centers, not the health ministry centers, were enough. But this has shown us, I don't know how we're going to go as a country, but I'm talking at a LATAM level. There's a lot of critical points about the self-tests. We need to make sure that they are adapted to users, that they are validated, and they can make sure of its quality. And also knowing what are the mechanisms or the distribution and sale channels that can have some type of formalization and that can have monitoring. We need to see what link we can have with the formal health system to be able to derive from and also have information. And for that, a question is how to cancel connectivity. The connected diagnostic tests could be very useful for epidemiology, for investigation, and for patients. I know it's a challenge. In the case of COVID, the recommendation from Dr. Rosanna Peeling that it's better to continue the virus presence as well, or residual in residual water. It's also something that we need to understand, that people need to be connected and understand what is the positive test, and that needs to be connected inside the health system in case of COVID, for example. And over the last years, we understood that there are barriers that we need to work with inside our health systems. The acceptance of results on the formal health system. Many times people would go with their own test and the system would say, no, we don't believe this. And they would have them do another test, but there were no other tests available. And it was really hard to get close to that. So at the end, you would lose the window of opportunity. There are economic interests as well, because the self-test has actually competes with labs that provide paid services for tests. And they may have, and they have had important lobbies about the regulations that have not allowed for people to sell self-tests for HIV in the past, for example. Now there are the changes in power dynamics, and they feel like that's what's happening, and how people are going to have control and health professionals are going to have control over something that before it was only limited to health professionals. So it's something we need to work on together. However, we can't not recognize that definitely as a tool of public health, it can increase coverage, it can reduce differences if we can make sure that they are available and they have similar prices, and it can be distributed through communitary agents. You know, that they are highly accepted by members of the community. They can empower members of the community, and they can also reduce the overload of health centers, leaving more time for those people who need more attention. So I would like to leave you. These are community agents in the Amazon, and they have also been working on another project talking to other women about tests and self-tests, and they take the tests and they train other people. So the future of health is in the hands of the people. And I believe that this is the time to empower and make the test more democratic through self-testing. And this is not going to damage health professionals or public health. Actually, on the contrary, it's going to strengthen public health involving the community. Thank you so much for your attention. And I will now go over to the next presenter. Thank you. Thank you, Professor Patricia Garcia. It was a very interesting presentation because it brings us this point of how these new technologies can have this in our favor, and not only technologies that are available for curiosity or individual use. So I think that's one of the main questions that we need to answer. Our third presenter, Elliot Cowan, he's a specialist of regulation in partner diagnosis, and he worked for FDA in vitro diagnosis. Unfortunately, couldn't be here with us today. He couldn't be connected at this moment. So he gave us a video that will be shown with his presentation. Thank you.
Many thanks to the organizers for the opportunity to be part of this important webinar, and my apologies for a scheduling conflict that didn't allow me to participate, so to speak, and to answer any questions you might have. Nonetheless, I hope I can provide you with some useful information on how the US FDA has and is handling self-tests, focusing on self-tests for SARS-CoV-2. The actions they've taken could very well open the door to self-tests for other conditions.
Bruno, se você
Let's
puder
start with
colocar
some
no modo de
definitions.
apresentação, por favor.
This has been more of a challenge than you might think, as
Só um instante, por favor, e nós vamos colocar no modo apresentação.
Just a minute, we are going to put in the presentation mode.
there isn't a perfect one. This can include terms such as self-tests, at-home tests, and over-the-counter tests, all referring to the same type of device. So these tests these are tests that can be purchased and used by anyone at home. They don't require a doctor's prescription. If manufacturers intend to sell their test kits over the counter, they have to demonstrate that untrained laypersons can perform the tests and get good results. Again, note that no prescription is needed, giving individuals the opportunity to test themselves. Because of this, test performance needs to be evaluated in the hands of intended users in an intended use setting. On to a brief history of infectious disease over-the-counter tests in the US. I say brief because there really isn't a lot to discuss here. There are actually a number of cleared OTC tests for non-communicable diseases. Tests, for example, for cholesterol, menopause, ovulation, pregnancy, and prothrombin. However, when it comes to infectious disease over-the-counter tests, there remains only one, the HIV OTC test from OraSure that was approved in 2012. It wasn't until 4 years later that FDA convened a meeting to discuss risks and benefits of OTC tests for flu, for CT&G, and for strep A. For those interested, I included a link to the meeting materials, but in short, there was a recommendation for CT&G tests as a priority, followed by strep, along with a concern about self-collection of an oropharyngeal sample, followed by flu. There really was no activity in this area until 5 years later when the first OTC test for SARS-CoV-2 was given an emergency use authorization, or an EUA. Even then, that test wasn't authorized until about 1.5 years after the public health emergency was declared. FDA had actually identified what it expected to see in an EUA in July of 2020 when it published its template for manufacturers of molecular and antigen diagnostic COVID-19 tests for non-laboratory use. Non-lab use was FDA's term at that time for an OTC test or a self-test. This was followed by 2 revisions to clarify FDA's thinking on what information is needed to support an authorization. Also, FDA revised its policy guidance for COVID-19 tests in 2021. This policy guidance made clear FDA's priorities for COVID tests with a focus on increasing access, and it's important to note that this included the need for. Now, the templates play a very important role in the regulatory process for emergency use authorizations. They provide specific instructions on what FDA needs to see. They identify the exact wording it needs to see for such elements as the intended use and details on studies that are needed, including those for analytical studies. This would include limit of detection, detection of variants, which is an ongoing activity, of course, and cross-reactivity, as well as information on clinical performance studies to establish claims for positive and negative % agreement, similar to respectively sensitivity and specificity, but reflecting that there is actually no gold standard test for SARS-CoV-2. There's also a section on manufacturing capacity, so FDA can prioritize tests that can meet demand. Currently, that's set at 500,000 tests per week, or 2 million tests. This slide shows you yet another timeline, in this case showing when and how many tests were authorized relative to other events. I want to call your attention to the right-hand section of the timeline, which shows the number of authorized OTC COVID tests in each month. As I mentioned before, the first OTC test was authorized in October of 2021, with gradually increasing numbers over the next several months. This was preceded by publication of the revised OTC templates and revised policy guidance that prioritized authorization of OTC tests. As of now, or at least the last time that I checked, there are 15 authorized OTC antigen tests. I also want to mention that there are 3 authorized OTC molecular tests, though they are significantly more expensive than the antigen tests. Speaking of cost, antigen tests were being sold for about $25 to $35 US, meaning that many people who wanted to test themselves could not. In response, federal, state, and local jurisdictions made large purchases of OTC tests, again with the goal of increasing access, and those tests are being provided to the public at no charge. It's important to keep in mind that there are some issues with OTC testing. This includes challenges to reporting and tracking for public health agencies. Many of the tests don't have the ability to communicate test results to these authorities. Likewise, it's difficult to monitor test performance to determine if tests are actually meeting their claimed performance levels. However, there have been several recalls of tests that have had issues with false positive test results, and FDA is quick to act on those. Most antigen tests are packaged for serial testing, which people may not realize, with 2 tests per package. The intention is for someone to test once and, if negative, test again 24 to 48 hours later, especially if they have symptoms. It's likely that many users are not following this procedure and simply taking a single test. There have also been some issues with fraudulent tests and tests that are being marketed without an EUA, and again, FDA is quick to remove those tests from the market, or at least as quickly as it can. So, where to from here? Given FDA's experience with COVID self-testing, I think it's likely that FDA is going to be more open to OTC tests for other infectious agents. FDA is encouraging manufacturers of OTC COVID tests to receive a full marketing authorization rather than just an EUA, and this approach could set the stage for more open thinking on OTC tests for other infectious agents. There's also a greater public acceptance for self-testing with a greater sense of control over individuals' healthcare decisions. And finally, there's also the opportunity for telemedicine to play a very important role here, not only for cost and efficiency, but from a public health standpoint as well. So infected patients will very efficiently transmit their infections in public. So isolating from others can play a big role in preventing the spread of infection. I hope this provided you with some useful information. If you have any questions, here is my email. Please feel free to write. And again, my apologies for not being with you live for this discussion. Thank you very much again, and obrigado.
Agradeço aqui à distância pela,
So I'd like to thank the collaboration. It's interesting to see a country with different paradigms, different point of view, not only in regulation, but also in the professional practice that it's easier to assimilate procedures that are there for people. Carlos sent a message to us through chat that we have run out of time to have a discussion. So we ask for all of you that have questions, you could add these questions in the chat or in the Q&A that they will be answered in the end. So now, Carlos, Eduardo, I will thank you. And I thank everyone that presented and everyone that are participating here from this session. Thank you, Cláudio. I thank you in a special way for your attention and for your work that you've been doing the public health system. And it's a good example, and you are my inspiration for a lot of things.